Because last got it. All right, got to read a paragraph here. I think since this is the same group as as last time, you've met us. We've kind of done the whole PowerPoint and everything. So really, just we're going to dive in. We've been kind of working on some purpose built stuff built for you all to show you Anaplan in a context that we felt maybe more relatable, to you all using use cases and inputs from what you shared last time. So really, we were just going to kind of dive in there and save most of the time to give you a chance to ask questions and dialogue as we go through that. It is still a demo system, so there may be stuff where 1+1=3 or an act. It may not be fully wired up to function completely. So just know that it is still a demo system that was purpose built for you all. But we think it'll give you a better idea of what it could look like in a lens through which to view Anaplan that is more relatable to how you would use it and see it and view it on a day-to-day basis. And again, just as a reminder, kind of that validation of, I know you all are not higher education, but we've got 150 higher education clients that are using Anaplan and 2,400 or something other customers, of all shapes and sizes and across a ton of different industries that are using Anaplan that can kind of validate its effectiveness and ability to be leveraged for various different use cases. So um, with that, I think Curtis, I'm turning it over to you, and we can
Great.
kind of dive in. Unless Melissa, I guess let me pause here. Anything from your side, Melissa, or Linda, or Mike? Anything?
Yeah, just thoughts you've had since our last call, and then we
Oh,
can take it from there.
nothing specific for myself. I think we're just anxious to see something
Sure.
a little more applicable to what our daily lives are.
Yeah,
Got it.
yeah, no, so we've done some work with you know, medical centers. So we'll show you this model and we'll show some of it's going to be more of like an LRP, but it should be pretty relevant. I think you'll be able to visualize yourself with that data. I'm going to go off camera here just while I'm presenting so I don't distract myself by hate watching myself when I'm presenting. So 1 second here, and then I'll switch switch out of here. So real quick, just to level set everybody, what we're gonna do here today is we're gonna go through kind of an LRP and a planning model for a medical center. It also cuts across a bunch of different areas, such as clinicals and specialty groups, et cetera. And we'll go through and show you some of the capabilities of the system itself. So can everybody see? Oops. Screen with that too. Can everybody see my
Yep.
screen? It's weird. The box around it went up and then it went away. So just want to make sure. So you're seeing Anaplan right now.
Yeah, we're seeing the browser Anaplan. Yeah.
Okay, great, great, great. Okay, so first things first, just a level set. Again, Anaplan is a built for the cloud SaaS application, accessible through any browser. When you log in, you'll use your single sign-on. If you have dual authentication, it'll take you there as well. Now, where are we going to go from here? So slightly different model that we're going to show, because last time we were talking about mostly just like pro forma, project evaluation, initiatives, and other items like that. Here we're going to talk more about, it's going to be more of a scenario and planning model for an acute care facility that has medical centers, hospitals, has clinics, has various specialty groups, and so on and so forth. So again, as we go through this, what you'll see is this is also on a multi-year basis. The time horizons here might be a little bit off, so just visualize this as being, when we're imagine that whenever it says 2017, that it actually means 2023 or 4. et cetera, and going forward. So again, what you'll see here is you'll see a slightly different view of the world where, again, these are organized how you need to see fit, and how we want to show things. So we'll go through KPIs, Moody's. I believe that we're only talking about things at the medical center level, the hospital level, the acute care facility level. We're not at this entire health system, are we? No. Okay. So great. So I'll probably shy away from spending too much time on KPIs, Moody's, but maybe I'll show some of this for a little bit, just so you can get a feel for how things can look, or different views of how charts, graphs, and ways you can interact with the data might be, financial statements, acute care planning, physician production, expense management, et cetera. We'll go through these. You'll also notice that, again, I will typically be using this button here. So I've turned the logo into a homing button, which will always bring me back to this this landing page where I have, physician production planning. I've got inflation, growth planning through hospital drivers, revenue by source, different payer types, expense buildups, clinical expense, our various statements and reporting, balance sheet, cash flow planning. I'll probably shy away from debt, treasury, and M&A stuff, given the audience here. But we do have that, where if we were looking to acquire, say, ear, nose, and throat practice that has, a couple different, has five clinics and 35 physicians, et cetera, like, we could incorporate that into this model as well. And I'll briefly show on that. And then, we don't really, if there are any memorandums of understanding with the, related groups, we can get into that as well. So first things first, what I want to start with, I'm going to go through and scroll down, and I'm going to start from like a reporting view. So when we look at the income statement here, I'm going to look at the income statement, and what you'll see here is we have our various scenarios. So actual scenario, forecast, upside, some what ifs, your various reforecasts, et cetera, variance scenario. We also have our list of, our entities. So we have our total system, primary care clinics. Scrolling down, we have our specialty clinics, so arrhythmia, cardiology, cardiothoracic, et cetera, and our acute care facilities. So UNC Hospital is primarily where we're going to be focusing today, given the audience here. But getting into some of that information, as well as corporate. If we wanted to get into any administrative costs, we could do that as well. Now, again, what you'll see here is, as we go through this, what you'll see is you'll see the buildup of inpatient revenue, outpatient revenue, revenue deductions, bad debt, pro bono charity, contractual arrangements, capitation. And as I scroll down here, what you'll see are different views. So you'll see these different scenarios here. We have, primarily budget and forecast, where we're going to be living today. But here I can see my various expenses as well. So salaries, contract labor, et cetera, going down our P&L. As we go through this, what you can also get into is, so say we want to go in here and say our bad debt expense, or say, I'm going to say inpatient revenue. So if I go here and I drill down into this information, again, you'll see, I can see my admissions, I can see my inpatient gross patient revenue per admit. I can see how my admissions are being calculated. So I can see that this met 56,000 admissions. I have my various payer types broken down by my admits as well. And I can continue to go down here. So say self-pay, got 560. I can go ahead and see how that's being derived. So in here, we're just taking the last period and growing it by 1%. So I'll show you, we'll go into how actually drive that revenue. But first I want to look at, so what do we have here? We have the statements. I want to show the statements, and then I want to go into how we actually get to the numbers that we are going to, that actually build up to this. So how do we flex our drivers? How do we run scenarios? How do we manage the business and the organization, right? So I want to give you a feel for what things can look like from an output perspective, and then we'll go through and actually make the inputs, and then we'll go through and actually update those inputs, and then we'll circle back to the outputs again. So again, here what we have is we have a view of, monthly financial statements. So let's say here I do not want to see 17, and I only want to see annual data, no quarterly information. I just go here, I refresh. Now I can see that information. Oops. Go ahead, refresh this again. So now I have all my information across the bottom, and you'll notice that as I select these on and off, and I refresh, the information updates. Now, if I want to go ahead and say I want, for 2019, I want to have monthly data, this information is here. And here, this is actually how we're building up this information. Sometimes we're building it up, sometimes we're forecasting things at a high level and spreading it back. Anaplan is a very flexible tool and allows us to very easily, forecast at a high level and also build up from a bottoms up perspective. And typically those go hand in hand, right? So when you're doing your planning process, you are typically going through and, setting a target and then building it up, and maybe bridging any gaps as well as actualizing actuals as they come in on a monthly basis to do reforecasting. So again, here we have monthly details. We have this going out multiple years. Here, if I want to add 2023, refresh this, and you'll see 2023 over here. So again, this was viewable all at whatever level we want. So if we look at, Chatham, if we look at Surgery General, we can see where these are. So physical medicine, and you'll see all the information down below change. These are just various different reporting views. Now, if I do want to go ahead and expand this, and I want to drill into this information a little bit differently, or if I say I want to go ahead and I want to, let's say pivot this information around and say I want to see centers for a given line item, and say I'm going to go in here and say operating revenue. You'll see some of the information is going to be very similar, especially in these early periods. And for their clinics, they're a little bit different when we get into the specialty groups. So if you focus down here, you'll see the difference, and you can see it by month across our various specialty clinics and acute hospital facilities. I also have the ability to go ahead and say I want to also put versions across the columns, or say I want to see it this way. Now I can see my actual scenarios and how that gets actualized, as well as in the forecast period, in the forecast space as well. Say I want to go ahead and under versions, I only want to show my forecast and my upside scenarios side by side. I can do that. If I want to see this other what if payer consolidation and say a variance scenario, I can go ahead and do that as well. And I can refine that list, and you'll see these right here. Now, the other thing I want to do is I'm going to go ahead and change this around a little bit again, so that I can go ahead and I'm going to pick a given period in time instead of having all of my time side by side. So now if I go say FY18, I can go ahead and see my forecast, my upside, this other scenario I was doing, as well as the variance, and now variance for these scenarios as well. So I'm going to go back to the other page, and you'll see that I have that information down below now. Now, if I want to go ahead and go to, say my balance sheet, I have, you know, fully forecastable balance sheet cash flow as well. I'm not going to focus too much time on this given the audience, but if we do start acquiring different physicians groups, you'd want to have a strong balance sheet. And you want to have the debt or cash on the books to be able to pay for that. Again, this is a 3-statement financial model. So we have net income flowing through. We have the ability to alter our AR, AP, etc., and have that flow through to get to a cash flow number and a free cash flow number. You know, if we want to go back and go back to talking about our net operating income, our NOI, we can go back to our hospital revenue drivers. And what you'll see here, you'll notice that we have this set up where we have admissions growth, we have visits, and you'll notice right now I'm at total system. So let me real quick go here. I'm going to go to UNC hospitals. So now you'll see that I'm in my forecast scenario. I'm going to switch this over to the upside scenario so I can see the changes, and say my admissions growth is going to go up by, I'm just going to pick some numbers here, say 5%. You'll notice that as I do this, all of my charts, graphs, and everything like that will update in real time. So if I go here and I say 5% across the board, you'll see now I'm obviously much more staggered. Visits growth, I'll put that as 5% again. You'll see that impacts this way. Now, again, what I was saying is when we go through and we see how we interact with this data, again, these dashboards are totally configurable. So if I want to go ahead and edit a dashboard and say, like, I'm not seeing enough variance in this chart right here, I'm going to go ahead and I click that edit button. I'm going to go here, pull this down, and say, now I'll see a much larger group. Now, if I also want to go in here and add an instructions page here, I can go ahead and add this and say instructions, update admissions growth and visits growth for this scenario, for any scenario, by changing any variable below. So, and say I want to change this and I want this to be, I don't know, heading 3. I can go ahead and do that. And I'm going to resize this a little bit so that I have better. Say this, I want to make sure that I'm pulling this information over. So again, oops. I'll publish. So now I'll have that update here, and you'll see I have more variation in my chart and graph. Now, this chart here also, when we change these variables, we also have the ability to interact with these charts and graphs on the page. So if I were to go here and say admissions growth is going to grow by, I don't know, 20%, you'll see these change. So this is about $10 million in revenue deductions, capitation, almost $1 million. If I put this back to 975, and this is now less, really close to 10 million. So if we look down below, you'll see our inpatient admissions. We have a breakout of basically how we're being paid, right? So here we have our payer, our mix of patients, right? So how are they actually paying? Because we have different rates associated with those, from CPT code, from maybe the charge master schedule, and how we actually get reimbursed, at what rate we actually tend to get reimbursed, and maybe even bad debt as well. So maybe self-pays, bad debt is different than Blue Cross Blue Shield, right? So in this case, we have 17% Medicare, set 21% Medicaid managed. Say this changes over time, and say that this area is becoming more affluent. So we can go ahead and say this is going to be 20. This would be 19, and this would be 18. And I go through and I'm going to go ahead and say that Blue Cross is going to be 13, 14, 15. We have a higher reimbursement rate there. That will actually later on change our reimbursement rates and how we're actually in the revenue that we're actually generating. So everything we talked about earlier, where we were talking about changing the admissions growth, the visits growth, all that flows through. Everything's it's similar to Excel. Everything, there's a formula and it's set up to be relationally based. It'll be relationally based. So here, if you look down below, outpatient visits. So say our outpatient mix, say Blue Cross Blue Shield is it's gonna go up. So 11%. Unless down below, that number will change. So here's 134. Say I were to go in here and say it's going to be 100, just to make it a really large number. You'll notice that right when I hit enter, Blue Cross Blue Shield will significantly change. So this just changes the mix. We want to always make sure that it equals 100%. So go there. And then down below, you'll see, some additional information. I'll get into some of this a little bit later as well, but these are some of our other drivers. So we'll have an inpatient gross patient revenue growth, inpatient admittance rates, outpatient growth, outpatient visit rates, any type of adjustments and changes, patient days growth. If we have, the number of beds that we have, we can see if our census data, our average stays causing we're over capacity. We can get into that as well. So you can see down below, we have our patient days, we have our outpatient increase, our inpatient gross patient revenue per admit, as well as the staffed beds that we have. So we'll continue going forward. We'll go to HASML revenue summary. Again, we have some of the same information, only now we have more of a detailed driver-based P&L by unit. So in this case, UNC hospitals, as well as by payer type. So here you'll see we have, our inpatient growth rate. So say that for our Medicare, so some of this is not going to change quite as much because we have broken it out into multiple different ways. So if I were to go here and look at, I'm going to stay with some of our larger percentages. So you'll see here, I've got a different mix of due to the payer. So I can go ahead and say here, so I have my overall admissions, say that my inpatient growth rate, say this is going to stay constant. We know what we have a feeling what this is because it's set by the government. But we're going to go ahead and say, Blue Cross Blue Shield, our inpatient gross patient revenue is going to grow by 4%, 3%, 4%, 4%, etc. I can see that, and I go down here, I have my inpatient, and then down below, I have my outpatient.
Hey, Curtis, can I ask a quick question?
Yeah.
So in this, what we're showing, which are all of these years being considered projected years, or are you able to load in and pretend that we're in fiscal year 19, and so I can see true actuals for 17 and 18, and then 19 through 23, I'm able to project on a unit?
Yes. So in this case, 17, this is an actual period. So while there are inputs here, we would typically lock this down.
Okay. Well, I'm just trying to navigate to understand, like, if I'm sharing a model that I've built, the software has the ability to show historical actuals.
Oh, 100%. Yeah.
We normally show, or I normally show 3 years, and then I'm a history, and then I'm building out 5 years, so that you have, you can see what's going on. It's hard, because the years are what they are. It was hard for me to tell which one is actual and which one are projected.
Yeah, a lot of times we'll put some conditional formatting, and I'll show you something on the expense side in a little bit. I don't think that we have good data in this model, but I can show you like how it would look. I believe we have the conditional formatting and
Okay.
the lockdown, like it's locked down. It's
Okay.
just not. Um,
And now we've
yeah.
been talking a lot about at the hospital level. I assume, that if we're opening up a new unit or expanding a unit, I can get to
Mhm.
a unit level that would be available to pull up.
Yes.
It doesn't, this isn't, I mean, 'cause I normally don't do anything at the hospital
So
level.
I'll show that in a little bit.
Okay.
I know part of it. Oh, am I breaking?
Curtis, you're breaking up from me. I don't know.
Yeah.
Okay, yeah, I think it's all of us.
That because you're breaking up on me, Russ.
Um, I don't know. Melissa, am I breaking up as well, or is it?
No, I can hear Russ. Curtis was breaking up.
Yeah.
All right, give me a second here.
It's clear now. Maybe it was just
Oh, okay.
Yeah, it does seem better now.
I don't know. My computer sounds like sometimes when I'm presenting, I don't know if it just eats up a bunch of bandwidth or what, but
Yeah, it seems better now.
okay, great. So let me continue with this thought here, and then we'll go into into a little bit more detail, more on the expense side of the house here. But I'll continue going through it. Is this similar to like from an LRP perspective that you're used to dealing with?
Well, we have, on our financial statement sides, yeah, we have, historical data, and we can, you can look at the monthly and whatnot, in our current system, but that is just for like month end and, financial statements. When we're building pro formas, right now we don't have the ability to do that in the system, so it's completely different from that aspect.
Gotcha. Yeah, so this is a forecasting number one. I showed you some reporting. Now keep in mind that reporting that I did is on a historical basis and on a forecast basis. If we want to only look historically, we can obviously refine the views pretty easily. If you look down below, like here's where we have a bunch of our average census, average, et cetera. Adjusted occupied beds if we're doing an expansion here, say in 2021 or this period here, if we added 50 beds, we'd have that flow through. And then as we go, what just happened there? As we go forward, we can go ahead and like move this more like revenue by source. So here's where we have our various sources of revenue for inpatient and outpatient, as well as our contractual discount rate. And this is all by, obviously, by payer. These various rates, we can see where our revenue is coming from. Just different views of slicing and dicing this. If we did want to get into, say there's some type of payer consolidation impact analysis, where we wanted to go through and understand, all right, so if there's Blue Cross Blue Shield is going to buy a competitor, Aetna, or say there's some consolidation of payers in the Medicaid and the Medicare managed space. This is where we can go ahead and change our contractual discount rates, et cetera, and have that flow through to the financial statements, and we can see the impact on net patient revenue. So say two of them are going to consolidate, and we think that our discount rate is going to actually go down to, I don't know, say 80% in these periods, we would have that impact flow through. The next thing I wanted to get into is a little bit more granular. So say we wanted to go into doctor planning. So, and what I didn't want to do, and I know that you're focused on pro forma. We did some of the pro forma stuff around projects and initiatives. So I wanted to show some of the detail and not just spend the entire time inputting data. So what I'm going to do towards the end, just to level set, is I'm going to go ahead and add a new unit or a new initiative or entity. And then basically everything that you're seeing here, we would flow information through, or we would be inputting that information. So I know that the example you sent didn't really have any information in it, so it was a little difficult for us to totally rectify the way you have things laid out versus what we have in our models itself. So a couple things here. So here we have physicians. So we have the ability to pull in and add physicians into different facilities. So like here, if we go to UNC East, I have myself here. I have a various start date. So it's 2020. So let's say this is actually going to be 19. So I have an effective start date. You'll see that changes, and we'll run through into 2019. Now, what we have here is we have the expected net revenue that physician, Curtis Gratz, is expected to make. You can see that the employee ID, we do not, this is a to be hired position, so it doesn't exist. Here's the rough number of WRVUs that we're expecting, net revenue per RVU, and our implied compensation. If we wanted to go ahead and change some of this, so say he's an anesthesiologist, you can see the revenue that's being generated there as well. In addition to that, if we wanted to go down and see, all right, so Curtis Gratz, we have our net revenue, we have the WRVU, net revenue per WRVU, et cetera. If we want to go ahead and here and say, for this position, we are not going to accept the base rate, and we're going to go ahead and say, go here and say the implied compensation is, I don't know, $800,000. The net revenue is $2 million, et cetera. You'll see some of that flowing through. Unless I got the instead of 200, it's actually, let me go back and accept that base rate. So this should allow me to override that. Actually, it should be flowing through here. But in their charge, Curtis Gratz, RVU, implied compensation. All right. So this allows me to go through, override the net revenue, the WRVU. So say it's 6,000 net revenue per RVU, 200 implied compensation per RVU, et cetera. This allows me to override that rate up top here if I allow it to change it. So what will typically happen is we can go ahead and add new positions to the roster across these various clinics, across the specialties, et cetera. If we expand a clinic or a hospital or a specialty group, that would allow us to also add in additional resources and understand the revenue implications as well as the cost implications that would mean, right? So that would help pay for the expansion. Getting into like the payer mix. So here you can see the various payer mixes and net revenue by payer. So if I go in here and I say switch back to total payers, you can see the revenue being generated by each payer. And again, you can go in here and interact with the data similar to how we did on the other chart. If we actually want to even go in here and you want to open it up and we pull in the various CPT codes, we can actually go ahead and have these, pull these in from, I don't know what you use, Epic or something else, or we want to start layering these over the top and have them flow through. We can do very, very detailed level planning and have that roll up. I don't think that's something that you're looking to do, but we can do that. So we can actually get into all the positions that someone's going to do, or taking averages of those positions or what they've historically done, and pull that through, and going ahead and creating new procedures, and getting that information in here. Continuing forward, if we go to the expense management, this is where I wanted to go ahead and talk through in a little bit more detail. So again, I'm going to go ahead and change this from total system. I'll go back to UNC hospitals. What we have here is we have annual inflation rates, which then get spread back to the units, and then you'll see how I can adjust those as well. And then down below, you'll see right in this model, we actually, for this upside scenario, our actual, this is where I was talking about earlier, where our, where you can see the last historical period is actually November 17. So if I were to go ahead and, say this is an old forecast, if I were to go ahead and say, instead of, December 17th, I would go in here and say, let me actually change the year real quick. And I go to 2018. And here I can go ahead and say this is going to be, I don't know, say our April reforecast. See, I don't have data flowing through to this scenario, but this would be where you would see that data coming through, and that would be locked down. Is that helpful? This how it comes in. I just don't have data in this demo model for this scenario.
Yeah, that'd be cool.
So if that were to come through, it comes through, and then we forecast out the rest of the year. If I go back to my scenario here, I'm going to go back to my upside scenario and say for salaries, upside scenario, again, we have a lot of growth in 2018. So what we're going to do is we're going to actually go ahead and say, I have the option to go ahead and say, I'm going to go in here and say, I'm going to add, 5%. So that's going to add another, $6,000 or, $600,000, $600,000 actually is what it would be. Or if I want to go in here and say, I'm going to add another $100,000 here, I can see that change through and add to it. So if I drill down this, you'll see that I have my volume growth adjustment, my other adjustment, and I can see how it's being calculated. And this is the formula. This is actually probably good to see here while I'm in here. This is the math. So hopefully this looks pretty similar to what you're doing in Excel. Right? Like this is the formulas that within Anaplan. Pretty straightforward, right?
Yep.
The other area here that I thought would be good to cover here is every time you go ahead and input a value or make any change in the model for that matter, say I go in here and I want to see this value, you can see how that gets tracked. It's traceable everywhere in the model itself. So continue on, here's a unit level buildup. So I can go ahead and see, my expense buildup. I have obviously mostly salaries, but contract labor, employee benefits. So really these, 60% of the unit is all salaries. And then you have a lot of other costs involved in this, right? So as you look at this, we have, here's our salaries, here's our contract labor. This would actualize this actualizes as you realize. So like, as soon as the month is complete and closed, we would import that data, and that period, like say this January period, it would no longer be available to make any inputs, and it would be locked down, and the information would come straight from actuals from your ERP system. So here we have various adjustment growth. supplies, etc. We have the ability to go in here and adjust, similar to what we did on the last dashboard here as well. If we want to see the patient care, here's where we can see some of the metrics across various drivers. So if we look at number of FTEs that we have at this unit, drugs per FTE, supplies, etc., we can go ahead and see all that information across various periods. Now, I have this set up as FY18. If I go ahead and change this to be the full year, you'll see the monthly detail. And then various adjustment factors, and getting down to our expense buildup.
Does this system allow you to do, or is there a screen there where you can see the per unit costs, cost per case, or supply cost per case, or per discharge, or anything like that? Is there any? Is
Oh,
that
100%. It's all just math, right? So like
Okay.
if we're bringing in admission, if we're bringing in patient census data, if we're bringing in admits, discharges, etc., it's just math at the end of the day. Like
And then the other piece that our leadership likes to see, what you've shown here, whereas everything in total, but then it's the incremental from, if that FY18 is my baseline year, and I'm gonna grow over the next 5 years, I wanna know how much is because of this initiative we've done, separate from, okay, we're growing at 2% annually, and that without doing anything, we're growing at 2% annually. Now we're gonna have this intervention and intentionally do something, hire more people, expand beds or whatever. So they like to say, okay, well, this is where we were in 18, and now here's where we are in 19, and then let's calculate the incremental so we can just, over the 5 years, this is the incremental impact. And again, like you said, it's just math. It's going in and, saying, well, this minus this is just the incremental piece, rather than showing full year values across all of the years. We want that, we would want that plus the incremental part.
right. I mean, typically that would just be, let me go back to where I gotta figure out where I have something that, if you build a scenario, like, and you make all these adjustments, etc., or say you have specific adjustments, when I was showing earlier, you'll see this upside scenario. So if you say like this variance, here you just see the variance. Like, so I made all these inputs against a different scenario. These are the changes. So I made all these discrete inputs. I added a new facility. I increased my number of physicians, therefore I can generate more revenue. So for this unit, for UNC hospitals, like in FY23, we have, we're generating, $4 million extra dollars here, 181 million in net patient revenue.
Okay, so that in essence,
And this is a variance scenario, but you can create, that's against the baseline.
Okay, well, that's in essence does the same thing, yeah.
Yep. And you can get we've seen it where you do it like this, or we've also seen it where there's a huge grid where like every little thing can, like, I want to see this, I want to see these 10 different things. We can handle anything, to be honest.
Okay.
It's just how you want to interact with it. At a certain point with scenarios, you start losing track of everything, but depending on how many scenarios you run, but we provide the ability to apply narratives to try to help with that, right?
Okay, cool.
Technically, every input could be an interaction with the scenario, right?
Yeah.
And assuming it's set up relationally, you'll be in great shape because everything will just flow through. So I'm going to go back to, actually, let me use the homing button here. And I'll go back, scroll down. where were we?
Oh, one other question I had for you is, these graphs are lovely and stuff. Is there a button where you can, if someone wants to do a presentation, you can export it as a PDF?
Oh, anything you see here. So there's a couple different ways to do that. So if I were to go to, I don't know what dashboard I was on. If like revenue by source, that it. So see it down below. So number one, if I see this, I can go ahead, I can export as PDF
Okay.
easily. There's also formatted reports. So I don't have, again, we don't have any in this model. We have more presentation style reporting options as well, where we can put these types of reports if typically if they're more reoccurring in nature. But
Yeah, we tend to have standard views on each one of these pro formas. It's like, okay, we always want to look at this, this, and this.
Yep.
And so just to be able to, just export, and there's always the narrative that our partners in strategic planning or the clinicians or the folks in the operations start of it, the vice president of a specific area, they're putting together narratives. And so, and we would support that through, okay, here's the financial part of it. So I can export a document that then they can just include in theirs without someone having to go in and key it in and all that nonsense.
Yeah, so oftentimes I don't have this here. I can pull up a model a little bit later or send you a screenshot. I think we covered it on the last meeting, but if we want to embed that narrative into the dashboards themselves, we can do that.
Okay.
Both on a unit basis or a line item basis if we really want to. If you want to like say that we have that variance report and you want to see it set up where you have the scenario, the baseline scenario, the new scenario, like with values, say like 100 million, 105 million, and then the variance of 5 million, and then some explanation of what caused that variance, we can embed that right directly on the dashboard so that it's very transparent.
It's because right now what we do is we have an assumptions page and say, okay, here's all, you have the assumptions for like rates and stuff. Well, we also put in there and say, well, this is what this is based on. So it's kind of text saying, okay, well, this is about, this, the ORs, and we're expanding and we're adding 2 rooms and it's based on this location. When Melissa and I are building this, we on one of the front pages, like, okay, here's what this is based on. So we're all clear on what my baseline is and how this is being built. So that's, like I said, that's always a tab for us that lays out what we're doing. So yeah, do something like that.
Yeah, this is a good place to, again, this is not, I just don't have that type of stuff in that model. So I'm just going to pull up another model real quick here.
Jose, what's your question?
Yeah,
So-
I wanted to ask is, well, you know how we generate, the financials is one view. But one of the questions we get is like, how many statistics are generated? What other downstream stats or related stats are generated? I'm just curious how we can link and have that also be, part of what's populated. For every visit, you get all these other statistics that are generated or anticipated.
If we can get it, we can calculate whatever it is that you want. We just have to have the underlying data. There's no limit with Anaplan. Like typically I showed a number of statistics in the model I was showing earlier. That is, you're only limited by by the data that you have.
So, Jose, said another way, one of the strengths really of Anaplan, bringing in not only financial but also non-financial data, so we're able to just kind of represent however makes the most sense graphically or just raw data, whatever, those data points. But more importantly is the fact that now all that data lives together to create metrics or KPIs where it's a this per this calculation that you need 2 disparate data sources to calculate. Now you have that all living together, so it becomes very easy to create those kind of dashboards that have the various KPIs that you're able to do from these different data feeds and data sources. So As far as kind of out of the box, I mean, we normally come with a perspective of things that we've seen before, or KPIs that we, you know, are generally important. But most of the time, that's the area where we, you know, every leadership team is a little bit different. So we kind of rely on your team to say, hey, this is what we want to see or surface, you know, at the on the, you know, prime dashboards, if you will. So does that make sense? Does that answer your question, or do you want to go deeper on that?
It does. It just seems like there's just a little more infrastructure to build into the platform. And if you want the right output, you got to get the right inputs. You know?
Mm.
That's pretty much true with any system, Jose.
Right. I mean, like, if we're just thinking of what resides in Strata now, you know, might just be you can pull it out of Strata, put it in here. You know, you got to continue to, unless you could just tap into Strata. I'm just thinking how easy something like that might be, and without having to refresh data sets to get a different assumption outlook.
Well, but this is for, you know, not for month-end processing. This is for building models. So, and they're going to be updating, they would be updating monthly anyway. I mean, it's keeping perspective on what need we're trying to address.
I mean, if we need information to calculate some type of metric, yeah, we need the information. If we want it to be able to be updated in real time, we're not limited by what we do, but we can bring in all that information, and we typically, it's like a one-time setup. Once it's set up, it just always comes, whether it's from the ERP or
There'd have to be a monthly interface, I assume.
typically it's nightly, but
Nightly? Okay, cool.
might only
Better.
be relevant monthly, right?
Well, when we're building stuff, you
Yeah.
know, I'm building history and then, you know, building forward. So it's always nice to get the payments up to date for wherever you are currently, but largely when I'm building, or we're building something, it's looking back, you know, 2 to 3 years and then looking at the current year to date.
Like for example, like here's like FTEs per WRVU, average salary, drugs.
Mhm.
Like, are these like kind of what you're talking about? I mean, this is simple, right? It's a dollar amount divided by how many RVUs were worked.
Well, we have some statistics that talk to, they're set up, such that if I want to know how many operating room cases we have, you know, that department has a cajillion revenue codes that are generating revenue, but we're only counting only counting specific ones because the other ones are implants or supplies or something else. So it's, you know, there's some specific there's just some specific statistical accounts, we call them, that it's like, okay, well, I'm going to count this. So this is, you know, that you care about the other stuff because it's, you know, generating revenue. But if you're trying to just know volume, you can go in and look.
Yeah, so like in this model, what we're doing is we're calculating the stuff in history, and then we're growing it forward. So like average salary, drugs, supplies, like we're basically inflating it right here.
Right, right. And we do, I mean, that's, you know, historically, that's how we've done our modeling. It is at a pretty high level. Now we're getting into, if we add this, I can tell that it creates, you know, if I'm adding somebody that is newly diagnosed with a specific kind of cancer, Melissa and I can go in and look at historically and say, okay, historically over the last 3 years, that type of diagnosis leads to 8 chemo treatments, 1 trip to an MRI for this diagnosis code, and sometimes a small percent of the population chooses radiation oncology and another percent of the population goes the surgical route. So then we can plan at a high level saying, you know, what we anticipate just based on history is like, well, we've got 3 years that tells us generally, and they're usually pretty correlated, that says, you know, this is, you add this kind of a diagnosis and this is generally how that patient cohort will get treated.
Yep.
Uh,
Yeah, it's patient encounter. Like
yeah,
here's the typical
yeah,
uh here's the two paths that they take, and
yep, yep.
they generate this amount of revenue and they cost this much to.
Yeah, exactly. And so now we're getting down and more so getting down to a CDM level. We've worked with some of the financial analysts to say, okay, well, when we pull it in like this is how you would budget it. When I'm doing this, I'm not really down at normally at the charge level saying, okay, I'm going to do 12 of these and 11 of these. It's at a gross level. It looks like this is growing that much. And basically you're just grossing up history. So it was like, well, if there's 12 last year, now there's 12 plus 5% or whatever. So
Well, like
that's,
if we do this type of bundle the
yeah, you're looking at an
bundle
entire,
procedure, like here's what it's going to cost if we do this many of this, and
right,
going to
right.
cost like, because like if you do it by actual procedure code, like some of them are modified, right, and you don't
Yeah,
reimburse.
exactly, exactly. We have a lot of those that they will modify the CPT code. So it gets kind of janky if you're in there and they're like, they have the 5-digit CPT code, but then they added PED at the end because it's a pediatrics case.
Yep.
And they want the people that are picking supplies to know to pick it for a peds case, not an adult's case. So, they do stuff like that. It just, again, it makes it a little more, it just takes a little more work when you're pulling out to make sure you've got all the data. So that's where you go back and make, okay, when I pulled this, it says I've done 100 of these. Is that what my statistics also say? Good, it's a trust and verify. So then we'll go back to the statistics and say, yep, I've got them all. So
Yep. So a couple things. I know that we were supposed to end at 3:15, so I wanted to cover one more thing real quick. So that would be, well, actually two more things. So balance sheet, doesn't sound like we need to get into that too much. Like our working capital assumptions, CapEx, I mean, maybe some of the CapEx planning. But we do have the ability to go in here, run out our existing CapEx, run out our revenue across the system, and then incremental CapEx. So if we wanted to go in here and say create a new asset, we can go ahead and fill out the form, residual life, et cetera, like all of these we can layer on. But what I think is important to understand with all of this, given what I've heard today, is when we look at and go into say centers management here. So if we go in here and we want to go ahead and say create a new center or a unit, whatever it is, like in the hierarchy, we can go ahead and say new let's see, new cardio. Put that under specialty clinics. Submit it here. And let's add it to it. So everything that we did earlier. So I scroll down here, you'll see new cardio specialty. You can build this thing up from scratch right here. It's just a blank template, right? And then you'll see over here. Keep scrolling down. Right here's the new cardio specialty clinic. So
if you're trying to, if I'm opening up a new location and I want it to be just like another one, can you copy one so you don't have to repopulate everything? It's
yep,
like I'm gonna have the
same
same.
thing with the scenarios too. If you want to create a copy of a scenario, very easy to just copy. Literally, it takes like 2 seconds.
Okay. So if you want an aggressive scenario versus a, moderate scenario or something, you can have both built out there, and saved under different names or whatever.
Yeah. So 1 second here, and I can show you real quick.
In the past, I've had to try and modify payer mixes too, so that was nice to see that that's dynamic because there was a project where we were trying to anticipate more of a certain payer.
So I do not have this rendered on a dashboard, but
Right.
typically, like you typically would. I just want to show you how easy it is to do this because I think it's actually really powerful. So if I go in here and I do like say across different scenarios, so I do this bulk copy.
Mhm.
I can do that across anything. So these are all my lists.
Uh-huh,
So these are the dimensional members.
right.
I think it was centers L2. So what we were talking about earlier. So say I want to go in here and say specialty clinics, and I want to say I don't know why it's not letting me do it, but I go here. Why is it not letting me do it? There. And then we have our that new one we did. So
Mhm.
I click my source member, my target member, and typically we'd render this on a dashboard. I'm kind of going, giving you a peek under the hood. That's where I'd click OK to copy that. So I know I can show it to you here from a version perspective. So if I go out of this and I go to bulk copy and I want to say I want to go, I don't know, I'm going to forecast and I'm going to push it to my budget. So every single input that has been made in the model, I'm moving from forecast to my budget.
Okay,
That's every single thing. I'll say bulk copy. I've just copied 2.15 million cells.
okay.
So I just thought it's kind of under the hood. Typically we render everything on the dashboards for you. And then we teach you how to do that, but thought that would be helpful for you.
No, that is, I mean, because again, Melissa and I've been caught in situations where it's like, okay, we want an aggressive one, and then we want something more moderate. And what if we add another faculty member? We don't want to lose everything you've already done, so we ended up with several file version names, and you're adding dates and whatever. So,
Yep.
it's just cumbersome. So this, having a way to copy stuff over and then just change the few things that you want to.
So like this scenario that we just ran when we added that new specialty clinic, the inputs I would expect you to make would be you create the unit, you go to CapEx, you build out the build out, and then you'd
Mhm.
probably go to the faculty member or physician or practicing physician on the physician planning dashboard that I was on.
Mhm.
That would generate the revenue and expense, and then the rest of the P&L might be generated for you because there's a number of support staff for X number of physicians, et cetera, per unit. Like we'd try to plumb that for you, so that it at least give you a directional
No,
assessment.
yeah, that's nice because right now, we go and we have to ask the department, what is your job codes? What's this, what's that? Nothing is pulled automatically for us. It's like, so if we could go and look at the current department that we're trying to expand and look at the ratio of their staff and their productivity metrics. It's like, all right, I have to add this much volume, would this get them another FTE? And really largely now with our physician partners, they wait till they see our side and then they look and see, okay, well, if that volume is going to generate this many work RVUs and our expectations for a faculty member in this department is X number of work RVUs. So then they'll kind of back into, okay, that means for this initiative, we need to hire another half of a radiologist, or we make the expectation that all of our current radiologists have to up their work RVUs by 500 or something like
Yep.
that. So they're looking at what we're pushing out and then saying, okay, which works fine. Right now, Melissa's working on a huge model with about 10 different cancer subspecialties that she's pulling all this historical data on, and we're grossing up what we need. And then she works with our colleague in the faculty practice plan, and all those bits and pieces of these different diagnoses individually probably wouldn't generate, a need for another radiologist. But when you're looking at 10 of them, oh, when we get this whole project over there, well, that might indeed be another entire radiologist and another pathologist because it's cancer. So just the ability to make this more dynamic where we can build it and then just have them sign into the model and look and say, well, this is what it looks like. Now add your part.
So
That-
like In that specific example right here, so say we did an expansion on the cardiology specialty group,
Uh-huh.
and they added 3 more practicing physicians. This right here is the staff FTEs that are necessary. So, and here we have is like 0.1 basically FTEs per every 1,000 RVU generated. So that would automatically flow through. So you have the FTEs, you have the salary, and then you can adjust it after that. But
Mm-hmm.
that's it. That's exactly how this example works.
That's great. Yeah.
All configurable to like the differences and nuances of your organization, but
And so can you do a composite one where, like I said, Melissa's got 10, they want to see each disease site individually, but then they want to see a roll up. So I assume this is capable of saying, okay, here's the 10 individuals, and then as a consolidation, it looks like this.
oh yeah, 100%.
Yeah, I mean, that's frequent because some of them, not every disease site is as profitable as another, and they lift on what we have to buy and whatnot. So that's where we're inputting the capital. It's like, okay, for this initiative, it needs, we need to buy another whatever. Labs is asking for some $500,000 piece of equipment. So we load that in on the capital tab and then link back the depreciation and all of that. So you know, it just kind of is what it is. And it would be nice to see that, we wouldn't have to monkey around with formulas and whatnot, which is, like we talked about before, we're in Excel hell trying to, okay, what's our interim year? What's our baseline and so on. So it'd be very
Like,
nice.
so like, for example, in this case, if we add it, we've got it pre-plumbed with the useful lives, which then automatically generate
Okay.
which automatically generate the CapEx spend as well as the base depreciation as well as any incremental depreciation.
Cool.
So approve this.
Nice.